I'm making it, ma'am. It is now YouTube live, ma'am.
Okay. Over to you, Dr. Lakshmi.
Very good afternoon, one and all. It's a pleasure to welcome you all for this CCC series. This is episode 2, and this convener is Dr. Anju Soni, and we have none other than Dr. Alpesh Gandhi as a speaker. And we also welcome our two chairpersons, Dr. P.K. Shah and Dr. Suchitra Pandit. So I hand over to Dr. Anju Soni for further proceedings.
Thank you, Dr. Lakshmi. It's a great pleasure for all of us. Greetings and very warm welcome to everyone joining us today. I am Dr. Anju Soni, your convener for this pivotal web series of CCC infections in OBGYN, an initiative that has underscored our commitment to advancing women's health care. And it is an honor to facilitate these discussions, which are crucial for every healthcare professional dedicated to the field of obstetrics and gynecology. Today, we embark on a journey of learning and collaboration, addressing a subject so close to our hearts and critical to our practice of gynecological infections and their profound impact on one's health across the spectrum of gynecological, reproductive, and care. Zafar, why recording has stopped? Mr.
Ma'am,
Zafar?
yes, ma'am. We are trying to record. Sorry.
Okay. So you want me to start again?
Ma'am, we are trying. It's a technical issue. We will trying to resolve. Please
So
wait.
you let me know, please.
Okay, ma'am.
Yeah.
Yes, ma'am. It's started right now.
So I'll start again. Thank you, Dr. Lakshmi. Greetings and very warm welcome to everyone joining us today. I am Dr. Anju Soni, your convener of this web series on infections in OBGYN, an initiative that has a commitment to advancing women's healthcare. It is an honor to facilitate these discussions, which are very, very crucial for healthcare professionals dedicated to the field of obstetrics and gynecology. Today, we embark on a journey of learning and collaboration, addressing a subject close to our day-to-day practice, our heart, and is critical for our practice of gynecological infections and their profound impact on the woman's health across the spectrum of gynecological, reproductive, and obstetrics. I am particularly excited about today's session, featuring an oration of sepsis by none other than Dr. Alpesh Gandhi. Dr. Gandhi, past president of Foxy, Foxy, and many, including myself, during my tenure. He is a mentor for all of us. He has mentored me also during my tenure as chairperson of HIV and AIDS committee, Foxy, and a beacon of leadership, innovation. His contribution to the Foxys and the broader medical community has been both profound and transformative. Dr. Gandhi's insights today promise to enlighten us with a subject that is both urgent and essential for all of us. Moreover, we are privileged to have with us esteemed Dr. P.K. Shah sir and Dr. Suchitra Pandit as chairperson of this webinar, and their experience and dedication to the women's health have not only set up high standards, but also have inspired countless professionals in our field. Their leadership and their wisdom will undoubtedly enhance the richness of our discussions. As we proceed in today's webinar, the series of at large, let us embrace this opportunity to learn, share, and collaborate. Together, we can make significant strides in improving the gynecological and obstetrical reproductive health outcomes of women around the world. Thank you for joining us. Your participation reflects your commitment towards the excellence of healthcare, and I look forward to a productive and insightful session. And I welcome Dr. P.K. Shah, sir. He is a professor and unit head, Department of Obstetrics and Gynecology in Seon Hospital, LTMC Hospital, KEM Hospital, many hospitals in Mumbai. He's member of a lot of organizations, and he doesn't require any introduction. All of us know as imaging size master of the country. Over to you. A lot of journals, a lot of articles. We all know him so well. He has been given so many lectures in local as well as international subjects. He's got many lifetime achievement awards. Dr. Suchitra Pandit, past President Foxy, consultant OBGYN, Surya Hospital, chairperson AICC RCOG, President ISOPA, President Gestosis, President Foxy, and ICOG awardee, and also represented FOG, and also Mumbai OBGYN Society. She's also a big name for all of us. Welcome, both the chairperson. Over to you, sir, to introduce our great orator, Dr. Alpi Ekani, sir.
Sure. Thank you very much, Anju, for your kind introduction. And good afternoon, everyone, to this lovely web series on CCC, that is confusion to clarity to consensus. And this series of inflections in obstetrics and gynecology, today we have an oration by none other than our dear friend Dr. Alpesh Gandhi from Ahmedabad. And it is a great pleasure to introduce to you all Dr. Alpesh Gandhi. He was the Vice President of Foxy in 2013, and then he became President of Foxy in 2020. He was the Governing Council member of ICOG 2016-17, Chairperson of Practical Obstetric Committee of Foxy 2009 and 2011, Secretary of Gestosis India Chapter, past President of Ahmedabad OBGYN Society 2007-8, and this was the second time. The first time he was President of Ahmedabad OBGYN Society in 2003-2004. Past Joint Convener SOGOG, past Treasurer SOGOG, National Coordinator Emergency Obstetric Care EMOC, Program of Government of India and Foxy, member of PCPNDT Act Implementation and Supervisory Body for Ahmedabad District 2005 to 2008, and has been a practicing gynecologist since last 25 years. A very soft-spoken, fantastic human being that I have met in my life, and it's so nice to chair this session where he is going to deliver a talk or oration on role of obstetric HDU in maternal sepsis. Over to you, Alpesh Bhai.
Thank you, sir. It's a proud moment for me I'm going to deliver an oration in the presence of legends like Dr. P.K. Shah and Dr. Suchitra, who are going to chair this session, and they are also my mentor, from whom I have learned a lot. I'm so happy to hear good words from his mouth regarding me and my work in Foxy. I know Sir Dr. P.K. Shah since long. Don't go on his mistake. He has not come from army, but he is not less than army people, very disciplined, and we learned a lot discipline from him while working with him. Dr. Suchitra is like my sister, and at present I am President Justices. She was before me, she was President Justices. We have worked together for so many projects. I enjoyed working with her. Dr. Lakshmi Srikhande just completed a very successful and meaningful tenure of ICOG chairperson. Congratulations, Dr. Lakshmi. I'm happy to see you here.
Thank you.
And Dr. Anju, I would say I was also fortunate to work with you during my presidency. I was so very active 27 committee chairpersons with me, and I really enjoyed to work with all of you. I have seen you working very hard for a committee which usually people do not like to take, but you take this challenge, you motivated, you updated, you sensitize medical and paramedical and all of us in this difficult subject. And I have also seen you working in your practice very hard. I would like to congratulate you for this very interesting, very useful initiative. And thank you very much, all of you, for the kind words and personal introduction also. I'm going to speak, I'm going to give an oration on a very important topic. Can I share my... Can you all see my slides?
Yes,
Okay,
Sir.
thank you.
it's,
Thank you.
we can see.
So I'm going to speak on a topic, role of obstetric HDU in maternal sepsis. Whenever we discuss about maternal sepsis, whenever we come across a patient of suspected maternal sepsis, it is very important where to admit, where to manage. Triaging is very important because it affects the outcome. Obstetric sepsis is a critically ill, very high risk pregnancy. And to me, I believe that it is always to be managed in obstetric HDU because sepsis remain one of the 4 main causes of maternal mortality. Puerperal sepsis account for 10 to 12% of all maternal deaths globally. Sepsis caused 14.3% of pregnancy-related deaths in US during 2017 to 19, and in the UK, it accounts for as many as 25% of all maternal deaths. So whether it's a developing country or it's a developed country, all are affected with this sepsis. Maternal sepsis is one of the very leading cause for maternal deaths across the globe. Maternal sepsis causes at least 261,000 maternal deaths every year worldwide. And sad part is, WHO in 2018 declared that whenever a mother develops maternal sepsis, and from that, when she develops septic shock, 55 to 60% of such mothers with septic shocks died. The mortality rate is very, very high. More than half of the pregnant women die when they develop septic shock. That is why this is a very serious subject topic and should be managed, conditions should be managed in obstetric HDU. In India, sepsis is the cause of mortality after obstetric hemorrhage and HDP in all the states, including Kerala, Tamil Nadu, Maharashtra. These are the states in India which has the least maternal mortality between 20 to 40, but still they all are also facing a maternal sepsis as a challenge. I would also like to bring few eye openers. More than 50% of women who died from sepsis have one or more chronic comorbidity, including maybe diabetes mellitus, maybe CHF, maybe chronic liver disease or chronic renal disease, or maybe any other chronic comorbidity. So we also need to tackle such chronic comorbidity, and that is why the importance of HDU again it is there. Pregnant women who who have a chronic condition impacting one of their organs are the most at risk from maternal sepsis. And again, sad part is, though we have so many potent, strong antibiotics, broad spectrum antibiotics in our practice since last 2-3 decades, but even though in spite of all this, there's increased incidence of sepsis, maternal sepsis increase over the last decade across the globe, maybe because of the older maternal age at delivery, maybe because of the increasing gestational diabetes mellitus, maybe because of the increasing incidence of obesity or environmental factor. According to one study of the National Inpatient Sample, it reported a 10% annual increase in the cases of maternal severe sepsis and sepsis-related deaths in the UK between 1998 and 2008. So since last 2 decades, we are facing that the increased incidence of maternal sepsis in spite of having the potent, strong antibiotics available everywhere. Maternal sepsis is a life-threatening condition that develops during pregnancy, during childbirth, or in the months following childbirth. It also complicates abortions and miscarriages. In addition to maternal concerns, the fetus is also at increased risk of miscarriage, stillbirth, preterm birth, and particularly women living in low middle income countries like us have the highest rates of maternal sepsis, 150 women per 10,000 live births. And in case of stillbirths, 10 to 20% of the mothers are associated with infection in high income countries, whereas in countries like us, 40 to 50% of the stillbirths are associated with sepsis. Maternal deaths from sepsis are largely preventable if they are managed properly, and if they are diagnosed timely, and if delay is not done, and if they are managed in the obstetric HDU. But delay in suspicion, delay in diagnosis, delay in admission in HDU is dangerous. When infection occurs, body shows inadequate innate immunity and sign symptoms does not appear, but sometimes there is inadequate response to infection and the sign symptoms of the infection appears and we come to know about the infection. But when body shows innate immune dysregulation, organ dysfunction occurs, and that is known as sepsis. And maternal sepsis is always challenging to be managed because there is overlapping between physiological changes occurring because of the pregnancy and inflammatory changes occurring, and sign symptoms occur because of the inflammatory response because of the sepsis are less distinctive. They are overlapping. For example, high pulse rate, low blood pressure are common findings in pregnancy and sepsis both. So sometimes it becomes difficult for early diagnosis or early prediction. At the same time, disease progression is much more rapid in case when there is a maternal sepsis. There is faster development of complications, both maternal as well as neonatal fetal complications. Our patients look very young. Our patients are young and look very well until they are almost serious. And that is why also there can be delay. it can lead to many fatal maternal complications like ARDS, acute renal failure, multi-organ failure, coagulopathy, maternal death, encephalopathy. All such complications cannot be managed in routine flow. And it can also lead to serious neonatal complications like abortion, preterm birth, neonatal septicemia, stillbirth. Again, we need obstetric HDU to manage such complications. Complications develop faster, as I discussed, and delay is dangerous. Early suspicious is required, and early admission in obstetric HDU is important. So how to do early suspicious or early diagnosis? We can diagnose early from the clinical features as well as from the laboratory diagnosis, laboratory findings. When we come across a patient, a mother with any of these clinical features like fever with tachycardia, breathlessness, tachypnea, diaphoresis, we should immediately suspect that this mother can have maternal sepsis, diarrhea, vomiting. This may indicate exotoxin production, hypotension, shock. Mother may have urinary symptoms, renal angle tenderness, decrease urine output, or there can be anuria. Sometimes mother may have pain, abdominal pain, pelvic pain, and tenderness, wound infection, and her mental status is altered. So these are the clinical features from which we can suspect that this mother may be likely to have maternal sepsis. And these are the investigations we should immediately advise the mother to undergo these investigations, particularly hemoglobin, complete blood count, mainly for this total blood cell, total white blood cell count. There can be a C-reactive protein, CRP can also be advised, but it is not much useful because it suggests inflammation and it can be present there. CRP can be increased in many other conditions as well. But procalcitonin again is important investigations, particularly it suggests bacterial infection. Blood sugar, again, it's very important. Even in a non-diabetic patient, there can be hyperglycemia, serum creatinine may be increased, serum lactate may be increased, and this is a very risky. When serum lactate is increased, it suggests metabolic acidosis. INR may be more than 1.5. In such cases, we may have to advise for further investigations of coagulopathy. We should send blood and pus for the culture and sensitivity to identify the which bacteria is responsible, about the severity, and about the antibiotic to which this bacteria is sensitive. Urine routine micro, sonography, particularly abdomen pelvis, when we are suspecting some incomplete abortion or perforation or any foreign body or fullness in the pouch of the glass, like pus collection in the pouch of the glass, or so many things. When we are suspecting, we need to peritonitis, we need to ask for the sonography. Sometimes X-ray chest and X-ray abdomen also may be required. So from these investigations, we may come to know about the leukocytosis, leukopenia, thrombocytopenia, hypoxemia, positive culture, metabolic acidosis, liver enzymes, elevated liver enzymes, hyperglycemic status, elevated serum creatinine. We may be able to find associated DIC as a complication. So many things we can find from this laboratory findings. Immediately, we should advise all these findings, and immediately we should try to diagnose maternal sepsis. So when there is life-threatening organ dysfunction caused by a dysregulated host response to infection, it is known as the sepsis. But again, how to diagnose organ dysfunction or how to assess about the organ dysfunction, we can, for that, a sequential organ functional assessment score, SOFA, which is known as the SOFA score, is used. It is mainly used in the ICU. It is very useful, and there are certain criteria from which we can come to know about the findings. And if it is more than 2 criteria are present, then SOFA score, when SOFA score is more than 2, there is a poor risk. Again, when infection plus change of 2 or more parameters in the SOFA score, it is known as sepsis. And when sepsis with persistent hypotension is there, it is known as the septic shock. So this is the sequential organ failure assessment score, which is known as SOFA score. But as I told you, this is very useful, but also complicated, and that is why it is mainly used in the ICU and not in a routine practice. Not much in the routine practice. There is again another is obstetric modified score, which is known as sepsis in obstetric score, also available. But from this SOFA score, quick SOFA score is prepared, which is in which only 3 parameters are there: hypotension, systolic BP less than 100 millimeter of mercury, tachycardia, respiratory rate more than 22 per minute, and altered mental status. When more than 2 score is there, then 2 or more than 2 score is there, then there is a greater risk of poor outcome in sepsis. But again, many times we come across many pregnant women who has normal in routine condition, her blood pressure is between 90 to 100 and it is not abnormal for her. Similarly, there can be a little tachycardia. So for this, then later on, obstetrically modified SOFA score is prepared, and now we all are following this obstetrically modified SOFA score because this is a very simple score. When diastolic BP is less than 90 millimeter of mercury, when respiratory rate is equal to or more than 25 breaths per minute, and when alert mentalness is not there, this is 1 point is given for this, and when 2 or more score is there, then this score is positive and there is a greater risk of poor outcome. So from this, we can assess the condition, we can come to know about the organ failure dysfunction, we can come to know about the severity and the prediction of the outcome also. So early screening is important. Once we suspect or diagnose, immediately admission in the obstetric HDU is required. Immediately we should assess her condition with the obstetrically modified SOFA score or quick SOFA score, and immediately we should start managing her with septic bundle approach. Then what is important is what is septic bundle approach. What is actually bundle? Bundle is a structured way of patient's care for better outcome, a small straightforward set of evidence-based practices. When it is performed collectively and reliably, they have proven to improve patient outcome. They are well-established best practices, but they are often not performed uniformly, making treatment unreliable at many times. A bundle ties the care together into a package of intervention that people know must be followed for every patient every single time in certain frame of given time and sequence, and that this ultimately leads to a better outcome, improved outcome. These elements when used together improve outcomes more than when they use separately. Surviving Sepsis campaign is one such bundle. They are designed to allow teams to follow the timing, the sequence, and the goals of the individual element of the care. And usually this bring at least 25% reduction in mortality from severe sepsis. The first hour bundle should be immediately initiated within the first hour of the recognition of the sepsis. It's a multidisciplinary approach. It based on 2 phases, resuscitation phase and management phase. In resuscitation phase, immediately initial measures should be taken to take care of A, B, C, D, E, particularly a secure airway and take care of maintain breathing and circulation. This should be immediately done, and immediate monitoring in obstetric HDU of 5 important things should be done. 5 simple variables: heart rate, systolic BP, diastolic BP, respiratory rate, mental function, temperature. These are very simple variables but these are very, very important and useful monitoring a good surveillance for mother. And we should immediately follow sepsis 6 within 1 hour. So we should start high flow oxygen when there is impaired oxygen delivery. We should immediately start IV fluid resuscitation when there is a reduced organ dysfunction. We should immediately take blood culture, and we should, before starting broad spectrum antibiotic, and we should immediately start broad spectrum antibiotic without waiting for the result to come. It should be empirical, broad spectrum, and after the result of the culture and sensitivity, we can change the antibiotic if required. We should also send the blood sample for the other investigations, mainly hemoglobin, CBC, serum lactate, and other investigations. And accurately urine output monitoring should be started to direct measure of GFR. I will discuss all these 6 one by one, why it is and how it is. So oxygen should be administered to achieve a saturation of at least minimum or equal to 94%. And when patients are critically ill, a mixed venous oxygen saturation of 65% is the target as for the general population. Important is again fluid resuscitation. What is fluid resuscitation and how it is done and which fluid is to be used? Fluid resuscitation is required in all cases of hypovolemic and septic shock. Fluid resuscitation is the means administration of fluid rapidly and in boluses to patients with acutely impaired hemodynamic status. We should take IV line with wide bore needle like number 18, and it is also better if we can take 2 IV lines on both the sides. Which fluid is to be given is again an important decision. In our body, fluid is distributed in 3 compartments: intracellular, interstitial, and intravascular plasma. And we should give fluid we should give such fluid that it does not disturb the balance of fluid distribution in our body. It should maintain this balance. And there is a hypovolemic shock. So hypovolemia is there. So we need to replenish this in intravascular compartment. So we should use the fluid which is nearly equal to plasma, which has composition, pH, sodium, chloride, potassium, calcium, and mini osmolality. All these composition and properties equal to plasma. This is a very important table. Many times I found this very useful in my practice. When we look at this table, normal saline, ringal lactate, and plasma light A, all 3 these are the fluids, crystalloids, which has pH, sodium, chloride, potassium, calcium, and other properties are nearly equal to plasma. And that is why these are the very useful fluid. When there is a hypovolemic shock like septic shock, we should always go with these fluids, normal saline and ringal lactate. We should never use dextrose 5% or DNase or anything else, because dextrose 5% has only dextrose and water. Water immediately is easily permeable, immediately escape the intravascular compartment, reach to the intracellular compartment, and can lead to edema of the cells. And dextrose is rapidly metabolized, and so there will not be anything. It does not contain sodium, so hypotension will not be corrected. Hypovolemia, as water escape the compartment, will not be corrected, and too many of glucose may lead to diarrhea, and again can lead to hypovolemia. So please never use dextrose 5% and such fluid when patient is in hypovolemic shock. So immediately we should start resuscitation with normal saline. But again, after 1.5 or 2 liter of normal saline, we should always be watchful for hyperchloremic acidosis. Again, too much of ringal lactate, we should be watchful. Ringal lactate relatively is contraindicated in hyperkalemia. So start resuscitation with normal saline, and then we can switch over to ringal lactate also. So we should try to see the balance, and we should give this to fluid, and if available, plasma light A can also be used. So these are the fluids can be used when there is a patient is having septic shock and we require fluid resuscitation. As per the Surviving Sepsis campaign, it recommends an initial bolus of 30 ml per kilogram of balanced crystalloid for initial resuscitation, and then maintenance volume replacement in patient with sepsis and septic shock. But again, this recommendation is modified looking to the obstetrical condition recently by RCOG, and it has been modified to 20 milliliter per kilogram instead of 30 milliliter. 10 milliliter is reduced. So now the latest recommendation is 20 milliliter per kilogram by RCOG due to an increased risk of pulmonary edema in pregnancy caused by decreased colloid oncotic pressure. So this is very, very important to know which fluid is to be used, in how much quantity it should be used, in how much time it should be used, why it should be used. This all is very important. And a crystalloid is routinely practiced, though there is colloids, but colloids can cause anaphylaxis, can cause coagulation abnormalities, and starch can cause acute renal failure. So these colloids are usually not used. Colloids do not give any advantage over crystalloids in fluid resuscitation. Lesser cost and easily availability and safer profile go in favor of crystalloids. So use simple normal saline ringer lactate for the fluid resuscitation. And again, it is important. The older concept was to identify and to manage according to whether patient is still hypovolemic, euvolemic, or hypervolemic. But recent concept is to know whether patient is fluid responsive or not. And fluid responsive means that oxygen delivery to the tissues will improve after fluid administration. There are certain tests, certain criteria from which we can come to know about the fluid responsive. Previously, when patient is in ICU and when central line is taken, CVP from CVP, one can know about the fluid responsiveness, but CVP actually is not required for just to know the fluid responsiveness. It is never recommended. And we have simple measures like passive leg raising test, and now a sonography machine is easily available at all the places in all hospitals. So in a spontaneously breathing patient, there will be a change in the pulse pressure on passive leg raising of 45 degree. And we can, with the use of the sonography, we can measure the diameter of the inferior vena cava, and there should be, in spontaneously breathing normal patient, there should be a collapsibility of the inferior vena cava with inspiration. So if we can diagnose all these things, these are the very simple tests from which we can come to know about the fluid responsiveness. We can also there are other methods like pulse oximeter and many other things. I come to that. So after initial fluid resuscitation, further fluid therapy should be guided by dynamic measures of preload by using either pulse pressure variation or passive leg raising. And now we do not require central line to know the fluid responsiveness. So these are the findings from which also we can come to know whether fluid resuscitation is there, patient is fluid responsive or not. When MAP is more than 65 millimeter of mercury, when urine output increase 0.5 milliliter per kilogram per hour, when CBP is more than 8, when SCVO2 is more than 70%, when serum lactate level is normalized, when mental status is normalized. These are the indicators as per the Surviving Sepsis Campaign guideline from which we can come to know about the adequate fluid resuscitation. Heart rate is not a reliable indicator of adequate resuscitation. We should keep this in mind. With heart rate, these other things are also very, very important. And as discussed, fluid resuscitation should be initiated without delay immediately in the management of septic shock, with the aim to bring serum lactate less than 4 millimole and to achieve mean arterial pressure more than 65 millimeter of mercury. But in spite of all these measures of fluid resuscitation, about 50% of the hypotensive septic patients do not respond to fluid challenge, and they are better needed by vasopressor. They need inotropic support, and such patients should be shifted to ICU, and immediately inotropic support should be started. And this is algorithm for the inotropic support. Immediately noradrenaline drip at the rate of 0 to 10 micrograms should be started with the use of a syringe pump, infusion pump and syringe pump. And with this, if there is adequate BP and perfusion, we are done. If still persistent hypotension is there, then add vasopressin 0.04 units per minute. And with this, if there is good perfusion and adequate BP, again we are done. But still, if there is persistent hypotension, then titrate norepinephrine up to 25 microgram per minute. If it is there, BP is good and perfusion is good, it's okay. If perfusion is poor and still persistent hypotension is there, and if severe tachycardia is there, if facility of bedside echocardiogram is there, then we should go for bedside echocardiogram. If hyperkinetic ejection fraction is there, then continue up titrate norepinephrine. If it is not there, then epinephrine challenge test is done. If patient respond well with the epinephrine challenge test, then continue up titrate epinephrine and attempt down titration of the norepinephrine. So this is how the patient is managed when patient is on inotropic support. This is a simple algorithm, and again, with this is all about, we can say about the resuscitation, but we also need management, and for that we also need source control of the infection. We immediately need to identify the cause of the infection, where it is lying. We also need to identify where it is lying, and which are the possible bacteria or responsible infection for this condition. So commonly postpartum endometritis is very common after cesarean section delivery or after vaginal delivery. Septic abortion again is very, very important, particularly in India. At many places, this is responsible. Lower urinary tract infection again is very important. Chorioamnionitis, necrotizing fasciitis, toxic shock syndrome, all this can lead to sepsis, maternal sepsis, and can even not manage in time can lead to can lead to septic shock. There can be concurrent infection in women with severe sepsis, mainly maximum in 30% cases pneumonia and 30% cases genitourinary tract infections are there. Pyelonephritis in 6%, chorioamnionitis, endometritis, endocarditis, meningitis can also be there. But again, important for our practice is HIV, in India malaria, and again mastitis. Many times mastitis is forgotten. We should thoroughly ask and thoroughly examine patient, because mastitis is also very common in maternal sepsis, concurrent mastitis. So in maternal sepsis, E. coli and group B streptococcus are the most common bacterial pathogens, but the most severe outcomes are associated with E. coli and group A streptococcus. Empirical antibiotics are started to cover gram-positive, gram-negative and anaerobic organisms, and de-escalation is then implemented in accordance with culture results. Observational data suggested that 28-day mortality rate increases from 26 to 42% if there is delay in source control. So immediately with the resuscitation, we also need to control the source without any delay. This is very important, and for that we have many antibiotics, lot of choices there. So many antibiotics are available, and but we need to identify, we need to consider which should be used. Co-amoxiclav, please never use co-amoxiclav, because it does not cover MRSA or Pseudomonas, may increase risk of neonatal necrotizing enterocolitis. It should be avoided in pregnancy. Metronidazole only covers anaerobe, so single metronidazole alone cannot be used. It should be used in combination. Clindamycin covers most streptococci, staphylococci, including MRSA. Piperacillin tazobactam or meropenem covers all except MRSA. Ciprofloxacin or ciprofloxacin and metronidazole with clarithromycin can be given, or clindamycin and gentamicin as alternative in those with penicillin allergy can be given. In critically unwell patients, piperacillin tazobactam or meropenem and gentamicin or amikacin may be preferred. In my practice, I am routinely using, and I am getting very good result with piperacillin tazobactam or meropenem and amikacin. I am straightforward going for this combination when I suspect a patient is having severe sepsis. A simple regimen such as ampicillin once daily, gentamicin is recommended as first-line antibiotic for the treatment of chorioamnionitis as per the guideline WHO 2020. And combination of clindamycin and gentamicin is recommended as first-line antibiotic for the treatment of postpartum endometritis. These two are suggested by these are the as per the suggestion by the WHO 2020. Sometimes antibiotics alone are inadequate and drainage of abscess or removal of the infected material or surgery is required. Particularly, surgical drainage or removal of the infected tissue is important. We may require uterine evacuation, hysterectomy, abscess drainage depending on the etiology, and sometimes we may need cesarean section to perform cesarean section in case of chorioamnionitis. At this moment, I would like to also discuss briefly about the septic abortion. Abortion usually considered septic when there is a fever, offensive or purulent vaginal discharge, and other evidences of pelvic infection such as lower abdominal pain and tenderness is there. I want to discuss this because in India it is still prevalent at many places. 10% of abortion requires admission to hospital are septic abortions. Most of them are associated with incomplete abortion or following illegally induced abortions. It occurs when proper antiseptic and asepsis are not taken care, when there is incomplete evacuation, or when there is inadvertent injury occurs to the genital organs and adjacent structure, particularly bowel. So in this situation, septic abortion can occur, and microorganisms involved are routinely anaerobes, aerobes, which are found in vaginal flora. If we look at the pathology in septic abortion, then 80% of these cases organisms are endogenous in origin and infection is localized to the conceptus. But in 15% of the cases, infection produce localized endomyometritis, it can spread to the endometrium, myometrium, and in 5% of the cases, it can progress further. It can lead to generalized peritonitis, endotoxic shock, particularly in case of perforation of the uterus, injury to the gut, and such conditions. In toxic shock syndrome, usually group A streptococcus are responsible. In endotoxic shock, mostly E. coli or Clostridium welchi is there. Acute renal failure, again Clostridium welchi is there. So these are the few bacteria which can cause such septic abortions and such conditions. And when we are suspecting septic abortion, pelvic examination is very important to identify whether there is offensive purulent vaginal discharge is there or not, whether there is a bogey fill in the pouch of Douglas is there or not, which may suggest pelvic abscess, and also to identify the size of the uterus, softness of the uterus, uterine tenderness is there or not. These all are very important findings in the pelvic examination. And some certain special investigations are also required in case of septic abortion, particularly cervical and high vaginal swab for culture in aerobic and anaerobic media to identify the sensitivity of the microorganisms to antibiotic. Ultrasonography is very useful, particularly to know whether there is intrauterine retained product of conception is still there or not, pyometra is there or not, foreign body intrauterine or intraabdominal is there or not, whether there is a fluid in the peritoneal cavity or pouch of Douglas is there or not. So sonography and plain X-ray abdomen when there is suspected bowel injury is there or there. So these are the special investigation we need, particularly when we are thinking for the septic abortion. And sometimes we may need some active surgery in case of septic abortion, particularly when there is injury. We are suspecting injury to the uterus, suspected injury to bowel, when when there is a presence of foreign body in the abdomen, or when there is sonography by sonography X-ray or by by PB examination, PSPV examination. When we come to think there is something in the pouch of Douglas, when there is an unresponsive peritonitis or collection of pus inside the abdominal cavity. So in all these such cases, we may need active surgery, particularly mainly in case of septic abortion. So whenever, whichever antibiotic required or whenever surgery is required in case of septic abortion, immediately we should go for it because source control is very, very important. Once we control the source, then only patient will revive. Management, this is the principle of the management. We need a source control. Corticosteroid, the indication of corticosteroid in septic patient is a subject of controversy. Hydrocortisone should be reserved only for septic patients with respiratory shock, means those who remain hypotensive following initial fluid resuscitation and vasopressor, and patients receiving corticosteroids should be cautiously monitored for the hyperglycemia and hypernatremia. And as early as possible, we should withdraw the corticosteroid. Also, another benefit of corticosteroid is when we are suspecting a premature birth, it can be useful to accelerate fetal lung maturation. Again, glycemic control is very, very important. As I have discussed, in spite of patient does not have diabetes mellitus, glucose level may increase in septic maternal sepsis. So currently, all intensivists, majority of the intensivists aim to ensure glucose level less than 160 or 180, and they want to maintain glucose level less than 180, 160 to 180. This would be unlikely to adversely affect the baby, and uncontrolled hyperglycemia would be a greater threat. So it is very important to monitor the glucose, blood glucose level, and also try to maintain glycemic control. Deep vein thrombosis again is very important complication and very important condition. We need to take precautions, prophylaxis for the deep venous thrombosis, particularly in maternal sepsis, because prevention of DVT is essential in septic pregnant patient, as both pregnancy and sepsis are associated with hypercoagulability. Methods of prophylaxis are simple: use of compression stocking, intermittent lower limb compression, low molecular weight heparin, unfractionated heparin can be used. And when patient is on heparin, if required, monitoring should be done. But deep vein thrombosis prophylaxis is very, very important when maternal sepsis is there. Again, important is about role of intravenous immunoglobulin. It is usually not used, usually not in much practice or not much recommended. But when there is a severe invasive streptococcal or staphylococcal infection, and when other therapies have failed because of its immunomodulatory effect, it is sometimes used. Whenever immunoglobulin is recommended, it is used in high dose in pregnant women and is effective in exotoxic shock caused by streptococci and staphylococci. So we should keep this in mind, and rarely we may need to use intravenous immunoglobulin to manage severe sepsis, septic shock. And when patient is once monitoring and is continuing in the HDU, we should monitor the patient on with the MEOS chart, with the simple, as I have mentioned, for the surveillance, the simple vitals, temperature, systolic BP, diastolic BP, pulse, respiratory rate, mental alertness, urine outputs. These are very, very important. Patients should be continuously monitored in HDU, or if it is up, or if she is in ICU, for these parameters, vital parameters. Maternal sepsis has a significant impact on neonatal mortality. Over 1 million infections related to neonatal deaths occur every year. Particularly, intraamniotic infections cause maternal sepsis, pneumonia, respiratory distress, long-term neurological impairment in infant, and it can lead to neonatal encephalopathy and cerebral palsy, particularly in case of intrauterine infection. And in spite of immediately giving broad spectrum antibiotic, neonatal sepsis that may result in death or major disability in 39% of the cases, those affected with timely antimicrobial treatment. So we should be very much alert about the neonatal outcome and complications. And sometimes when we need to take decision for the delivery, the decision of delivering the fetus or continuing the pregnancy is influenced by patient condition, gestational age, fetal status, chorioamnionitis, and many other conditions, status and level of the labor, stage of the labor. Generally, in a critically ill pregnant woman, birth of the baby may be considered if it would be beneficial to mother or the baby or both. But we should also keep in mind attempting delivery of unstable mother may increases the maternal and fetal mortality rates unless the source of infection is intrauterine. So we should be very much careful in taking decision. And during the intrapartum period, if we are taking decision for the delivery, then during the intrapartum period, there should be continuous electronic fetal heart rate monitoring. It is recommended. And if we are going for the surgery, then surgical intervention, when it is mandatory, then septic hypotensive patient may not tolerate sympathetic block or vasodilatation associated with the spinal anesthesia. So the anesthetist has to make the decision about the regional anesthesia or the general anesthesia. Mainly general anesthesia is highly likely to be required, is practiced in a septic, in a maternal sepsis patient when surgical intervention is mandatory. Post-operative care and transfer to HDU, again transfer to HDU or ICU and not to general ward is again very, very important. And the decision and timing of transfer to intensive care should be decided by the critical care team or multi-speciality team, or a senior obstetrician should take the decision along with the in consultation with possible with the obstetric anesthetist. And these are the situations where we need to shift the patient to obstetric ICU, particularly when there is hypotension or raised serum lactate persisting in spite of fluid resuscitation, and when they require inotropic support, already about which we have discussed. When patient develop complications like pulmonary edema, when patient require airway protection, mechanical ventilation, when patient require renal dialysis, when patient's conscious level is significantly decreased, or when patient develops certain other lethal complications like multi-organ failure, which is very common in maternal sepsis and DIC. These two are very common and deadly complications when there is uncorrected acidosis, persistent hypothermia. When multi-speciality team approach is required, we should shift the patient, maternal sepsis patient, to obstetric ICU. These are the patients cannot be managed, never try to manage on general ward. They need obstetric HDU, and HDU. If they are not, if they have any such condition, then they should be shifted and managed to in obstetric ICU. Sometimes it can lead to DIC, and it is sometimes difficult. Sepsis can lead to DIC, and sometimes it becomes difficult to diagnose DIC. These are the simple laboratory investigations parameters from which we can confirm whether patient is having DIC or not. A platelet count, increase in fibrin marker, prothrombin mean time prolongation, and fibrinogen level. From these four simple laboratory investigations parameter, we can identify whether patient has DIC or not. This is a DIC score declared by the International Society on Thrombosis and Hemostasis, and according to the different laboratory values, different points are given. Suppose platelet is less than 50,000, then 2 points are given. Similarly, other points are given for the other findings of different laboratory parameters. And at the end, total of all these four parameters are done. And if it is between 0 to 4, DIC is not overt. So don't worry and continue monitoring, continue repeat score in 1 or 2 days. But when it is between 5 to 8, DI 8, then DIC is probable. Repeat score at frequent interval. Mainly, it is practiced at 4 to 12 hours interval. It is done. And when DIC is there, we should immediately ask our blood bank people also to be ready with the support of blood component. At least 4 units are required. And if we are giving blood, then replacement therapy should be guided by the laboratory assessment. Platelet count should be maintained about 50,000. Fibrinogen level should be maintained about 150 milligram. And hemoglobin level try to maintain above 9. Of course, 8 gram also is recommended at many by many guidelines. But try to maintain in Indian scenario, I would say, if possible, about 9. So these are the when we are suspecting DIC, and when we have to take care of DIC. This is about the DIC in briefly, and about the prevention of maternal sepsis. These are the guideline recommendation of WHO 2020 for the prevention of peripartum infection. Routine perineal and pubic shaving. Routine perineal pubic shaving prior to giving vaginal birth is not recommended. Intrapartum antibiotic administration to women with group B streptococcus colonization is recommended for prevention of early neonatal GBS infection. Routine antibiotic administration is recommended for women with preterm pre-labor rupture of membrane, for women undergoing manual removal of placenta, for women with a 3rd or 4th degree perineal tear, for women undergoing elective or emergency cesarean section, for vaginal cleansing with povidone iodine immediately before cesarean section is recommended. For cesarean section, prophylactic antibiotics should be given prior to skin incision rather than intraoperatively or after umbilical cord clamping. So before shifting the patient to the operation theater or in the operation theater before starting performing a cesarean section, prophylactic antibiotics should be given. For antibiotic prophylaxis for cesarean section, a single dose of first generation cephalosporin or penicillin should be used in preference to other classes of antibiotics. So these are the few recommendations for by WHO for to prevent maternal sepsis. We can take decision as per our clinical judgment, our situation environment of practice. We can take decision. And to take antiseptic and aseptic precautions, internal examination or operation, encourage abortion in legally practicing institutes only, to boost up family planning acceptance to prevent unwanted pregnancy, and to take care of pre-existing anemia, diabetes mellitus, and other comorbidities during preconceptional period, because in our country, anemia and diabetes mellitus is very prevalent. So we should take care for the anemia and diabetes mellitus, and we should try to control, we should try to improve status of anemia. And if it is patient is having diabetes mellitus, we should try to control diabetes mellitus before she becomes pregnant, and we should do proper counseling for this, so that later on she may not end up with the maternal sepsis and its complications. And we should also train our staff to take these challenges. We should train them for the behavioral changes. We should train them for the catheter associated UTI, sterility, strapping, local care, how to take care of the catheter, when to change, how to do skin preparation, how to do dressings, how to take care of IV lines, then position, oral hygiene, position hygiene, care of suctioning. All this we need to take care of all this care also, and for that we need to training regularly at certain interval of our paramedical staff. Also, health workers need to be adequately trained and skilled to be able to recognize the signs of sepsis early and also to treat the condition effectively. And they should also know about the critical care bundle, septic bundle. They should know about the all this prophylactic aspect, and they are basically involved with this such type of care of position care, oral hygiene, catheter care, skin care, IV line care. They should learn all these things at regular intervals. So in conclusion of this oration, I would say recognize obstetric sepsis and septic shock early. Remember inflammatory triad and signs of hypoperfusion, and do not wait for BP to fall. Patients should not land up with the septic shock. Otherwise, the mortality is 55 to 60%. Remember, always remember this. Patients should be identified, should be managed before patient develops septic shock. Manage the patient always in obstetric HDU. This is not a case condition which we can take care in on routine floor or ward. Immediately when we suspect this patient is likely to have obstetric sepsis, immediately counsel, immediately admit in obstetric HDU and start managing and monitoring in HDU. The surviving sepsis bundles are important. First, our goal is very important. Practice septic bundle approach within 1 hour. Try to resuscitate, then try to control the source of sepsis, remove the source of infection whenever it is required. Deliver the mother if it is in benefit of mother, fetus, or both, and if required, try to settle mother before delivering if possible. Support of multi-speciality team may be very useful. Neonatologist, anesthetist, sometimes we may need support from the urologist, nephrologist, cardiologist, so many other specialty we may need support, and to give supportive therapy, particularly in order to bring back to normal hemostatic and cellular mechanism once source of infection is removed, once the resuscitation is done, then also again after that we need to give supportive therapy and sometimes rehabilitation therapy like the also we may need, and to assess the response of the treatment at regular intervals, sometimes even at the interval of few hours and sometimes at the interval of few days are required to assess the response of the treatment. Remember, if it sounds like an infection from the history, if it sounds like an infection from the examination, do not wait for the results of the investigation. It is probably an infection and treat like it is an infection. What is best for the mother is always best for the fetus. Always we should keep these two things in our mind and manage. Try to prevent, or we should try to early diagnosis a case of a maternal sepsis, and always we should manage maternal sepsis in obstetric HDU before the invention of the obstetric HDU. I have data, but because of the paucity of time, I have not produced it here. But I have data, and it has shown that in different medical colleges, within 1 year, just within 1 year of advent of the obstetric HDU, the mortality rate because of the maternal sepsis reduced by 60 to 65% when they are managing obstetric HDU and when they were not previously managed in obstetric HDU. So thank you very much once again for this honor, for this oration, for your patient hearing, and for the kind
Thank you
Thank
very
you.
much, Alpesh, for excellent talk covering sepsis with the minutest details and not leaving anything for anyone to think of. I was listening to you right from first word to last word. We welcome Dr. Suchitra. Suchi, welcome. Yeah. But you missed Alpesh Bhai. He covered the subject so beautifully, and with permission of Dr. Anju and with Dr. Alpesh Gandhi's permission, can I say certain things?
Yes, sir. Always.
I joined the OBGYN House Post way back in 1977. And in those days, we used to see a lot of cases of septic abortion. 14-year-old girl undergoing hysterectomy because somebody has put a stick in her uterus to abort her, and patient coming in septic shock. Luckily, over a period of time, with good investigations, very good antibiotics, blood, I think we have reduced this rate of infection. We don't see such cases now, luckily, with the grace of God, and I hope we don't see it in future also. But it was a sad thing that we used to see or do ourselves hysterectomy in such young girls undergoing septic abortion. Secondly, when you talk about high dependency unit, it is not something that one has to really spend money on. Something very, very simple. And I personally feel that you are at the helm of affairs and you can push this, that each and every obstetric labor ward should have one cot designated as high dependency unit. And all those gadgets required to support a life of a woman with sepsis or even otherwise should be available. This is not happening even in institutions in which we are practicing or we have worked. So I think a time has come when not only FOXC, but also the Ministry of Health and Family Welfare, Government of India should say that we should have one cot designated as HDU with all the gadgets available. We as obstetricians are good at managing our serious patients. Rather than sending the patient to ICU and thinking that, okay, now everything will be all right, I think we are really good in managing our own patients. Whenever it is not possible, you can ask those people to come and opine or advise, modify the treatment. And when it is absolutely not possible, then only you transfer to obstetric ICU. Rather than keeping the patient in obstetric ICU, I think we should manage ourselves. Thank you very much for excellent
sir,
talk on the subject. We enjoyed. I can see Pratik, one of the coordinators.
Thank you, sir, for your
Super.
compliment and for your comments. And you are rightly mentioned previously. There were two types of separate rooms isolation, one for eclampsia and another for the septic abortion. Those were the days. And you are rightly mentioned about the facility at the labor ward level also, because nowadays in last 2 decades the incidence of high risk pregnancy has increased to 25%.
Absolutely.
And these are the data of Government of India, 20 to 25%, which were previously 5%, 6% during before 2000. So many high risk pregnancy we are taking care and they are delivering. We need such type of facility at all labor room levels, sir. Thank you for your.
Thank you, Alpesh bhai.
Thank you.
Suchi, comments.
Alpesh, I joined in a little late because I was in the OT. But whatever I've heard, yeah, I know it's an exhaustive talk, and it is so important because pregnancy and sepsis is still an important cause of maternal morbidity and mortality. We've come a long way, as Dr. Pikash has said. In 20 years, advent of antibiotics has made a significant difference for us, understanding about the fluid resuscitation. But what has also changed the complete picture is the availability of the obstetric HDU. So I think very, very important that everybody should have it. But I'm talking even of corporate sectors. Corporate sectors have got huge ICUs. So even there, they should be able to dedicate a complete section to just high risk obstetric patients which have been transferred. And the HDUs are really, they really would pave the way for a better care for the mother, because now today we understand a lot more about our patients than what we understood 20 years ago. Things have changed so much, and I think you brought out very beautifully what antibiotics are better, what are the current guidelines, what are the fluid strategies, how do you exactly know what are the fluid challenge tests. So I think those are very, very important. And the take home message was also excellent, that don't shy away from doing a multitasking and calling the multidisciplinary team, but start off with your your management of antibiotics, and ask somebody if you feel that you're not understanding, because ultimately at the end of the day obstetric sepsis jitna hum kam kar sakenge utna acha rahega, because we've now come to double figures as far as the maternal death rates are concerned. So we've got to get this down further. PPH and HDP are coming under control. Sepsis and anemia, the two, we still have to work very hard on. So Alpesh, I'm sure whatever you have spoken, the message is very loud and clear.
Can't hear you.
And calling us for the session. Thank you.
Thank you.
One more thing I want to say, and even Suchitra will agree with me, that we were at Sion Hospital and KEM Hospital. Whenever we wanted to shift serious patient to ICU, we never used to get a bed in ICU because all ICU beds used to be occupied. I'm not saying that elderly people used to occupy all the ICU beds, because I think even I have reached that age. But I think you have to have a one bed always available for obstetric serious patients. And if that can be done, we will save many lives. And with Dr. Jaideep Tank, Alpesh, you can push all these things together, and we should have a better ICUs for ourselves, because our patients don't get ICU care and the lives are lost. So thank you very much for such superb oration.
Thank you.
Thank you.
Anju, where is the plaque to be given to Dr. Alpesh?
It will be sent to Dr. Alpesh, sir.
Okay.
So we have been actually, Dr. Alpesh and we have been on discussion for this topic for last almost a month, and he always said, इस पे नहीं बोलना है. मैंने कहा, sir, आपको इसी पे ही बोलना है. I know you are going to give
मैंने
the
इसीलिए बोला कि I thought Jaideep has also delivered, so there can be repetition. So I thought it was the second oration, first
No,
oration also on
but
sepsis. So I
I
thought let us
sir,
have
you have been a Janak of HDU, I believe, for the country.
True.
And it was very important coming from your side. So I always imagined you giving this, covering this topic, and you have done it so beautifully. Thank you so much. And I'm also thankful to PK Shah sir, Dr. Suchitra Pandit ma'am, Dr. Lakshmi Shrikande, and also Pratik, who has been there with me all through. And he is a person who all of us know has lots of, to his own booty. So thank you, everyone.
your series will be successful because Pratik is there with you.
Thank you, sir.
Anju, thank
Thank
you very much. I think infection is not a topic which everybody likes, and you are a chairperson of this committee, and I have seen you working on this seriously, committedly, and I wish you all the very best. Thank you very much for having all of us together today. Thank you.
Thank you, Dr. Anju Soni, for inviting me. Congratulations on initiating this series very successfully. You have chosen fantastic orators, and every time we learn something new in this short space of time because we have people of the highest intellectual caliber who are delivering all. Thank you again for involving.
Pratik is a showstopper.
Thank you. Thank you and all the best, Anju.
Chalo.
Thank you, sir.
Thank you.
Thank you, ma'am. Thank you, everyone.
Thank you, Walter Bhushan, for being there
Thank you, ma'am.
always.
Always, ma'am. Thank you.